Good evening and welcome. My name is Megan Lovett and I serve the Boston College School of Theology and Ministry as Director of Continuing Education. Thanks to each of you for joining us tonight for our fourth Continuing Education webinar of the fall semester. As part of the school's mission, we offer an array of enrichment opportunities to foster Christian faith and promote lifelong learning. We do this by offering presentations such as this one, as well as online courses, videos, podcasts, and other resources for personal enrichment and professional development. Our fall online courses are underway. Our next cohort of courses start November 25th and include A People of Hope and Mary, the Mother of Jesus, both Advent courses. We are currently accepting enrollments in both of these courses. If you're interested in learning more about our online courses or would like to enroll in a Crossroads course, we will include a registration link in the chat. Thanks to our speaker for granting us permission to record today's webinar. Tomorrow, you will receive a follow-up email with details about accessing the recording when it is ready. At the end of the presentation, there will be an opportunity for Q&A. Please feel free to enter a question into the Q&A tab at the bottom of your screen at any time during the presentation. We will try to get to as many questions as possible. Finally, we are also able to offer live closed captioning for today's webinar. Please click on the closed captioning button on the bottom of your screen to enable the feature. Many thanks to Dot and Carolyn, graduate students here at the SDM, for providing the closed captioning for us today. I now invite Father Tom Stegman, Dean of the School of Theology and Ministry, to introduce our speaker.
Good evening, everyone, and welcome to tonight's presentation, Catholic End-of-Life Ethics and the COVID Crisis. It's my distinct pleasure to introduce our speaker. Dr. Daniel J. Daly is Associate Professor of Moral Theology here at the Boston College School of Theology and Ministry. Professor Daly earned his PhD across the street from here in the Theology Department. His PhD is in Theological Ethics. Before joining us at Boston College, he was an Associate Professor and also the Chair of the Theology Department at St. Anselm College in Manchester, New Hampshire. I'm going to go off script for just a second. Usually when somebody becomes chair of a department, they're being punished for their sins. But I know from one of Dan's colleagues, that, and this is a serious point, that he was chosen because he's a bridge builder and a team player. And that's certainly, those two characteristics have certainly been evident here. Now, speaking of team, another thing off the script, Dan's also a big baseball fan and he's still playing baseball. And I said, Dan, if you join this faculty, I hate to tell you, you're only going to be the second best player among the faculty members. You might wonder who the best one is. I'll give you two clues. He's left-handed and very modest. Professor Daly is an experienced clinical medical ethicist, having served on the ethics committees of the Catholic Medical Center and the Elliott Hospital in Manchester, New Hampshire. He's also a member of the Catholic Health Association's Theologian Ethicist Committee. Professor Daly is an active member of the Catholic Theological Society of America, the Society of Christian Ethics, and the Catholic Theological Ethics in the World Church Initiative. He has published several articles and book chapters on virtue ethics, the ethics of social structures, and medical ethics, including end-of-life ethics. He has a monograph that will be coming out early next year called The Structures of Virtue and Vice, published by Georgetown University Press, and we're eagerly looking forward to seeing the birth of that book. A wonderful teacher and scholar, a great friend to STM's continuing education program, we are delighted to have him join us here tonight. A warm welcome to Professor Daly.
Thank you so much, Father Stegman, for that wonderful introduction. And I couldn't agree more. I think you probably are the best baseball player to ever come through the STM faculty. Not saying a lot. That's not saying a lot, but I think it's probably true. Okay, let me try to share my screen here, which is what I've been asked to do. Here it is. One more thing here. Okay. Okay, good. So, welcome to Catholic End-of-Life Ethics and the COVID Crisis. And I'd like to begin just by thanking, and now it's not advancing. Oh, there we go. Okay. So I'd like to begin by thanking all the good people at the Continuing Ed program here at the STM, especially Megan Lovett, Kara O'Sullivan, and James Burriston. And a warm welcome to all of you tonight for tuning in. And a warm welcome to my aunt, Sister Ann Daly, who's a sister of Notre Dame. She just concluded a very long and distinguished career as an academic out at the Elms College in the western part of the state. So hi, Aunt Ann. I'm glad you're with us, and I look forward to seeing you soon. So let's get to the talk. The context of the talk is COVID-19. But really, we're dealing with twin pandemics. One is the COVID-19 crisis, which has killed over 220,000 people in our country alone in the past, 8 months. There's also the racial injustice pandemic that has gone on for far, far longer. And here you see this horrendous picture of George Floyd being murdered by a police officer in Minneapolis in May. And so the context of this twin pandemic, well, on the one hand, we've got COVID. On the other hand, we have racial injustice. Both kill, and both kill Black people at a disproportionate rate. Obviously, racial injustice has a long history of killing Black people and leading to their diminished lives. And COVID-19 has been selecting for African Americans and Black people through this pandemic. And we'll talk about the ways in which that's happened as the talk moves forward. So the goals of this lecture. Really what I'm after is, what does Catholic end-of-life ethics have to contribute to the nation, and I would also say the world, during the COVID crisis? During a pandemic, during a crisis like this, we need good ethical reflection more than ever. And I think that the Catholic tradition has a lot to offer. So what I'd like to do is explain some of the core concepts and methods of Catholic ethics, Catholic end-of-life ethics, and what's called the ars moriendi tradition. That is the art of dying well. The Catholic Church has this long tradition that says that we can die a good death. And we'll talk about that as well. Then I want to take these insights, take this tradition, and apply Catholic ethics to the COVID crisis. In what ways does Catholic ethics illumine better solutions to problems that we're facing during the crisis? I think there are many. Part 1, foundational Catholic values. So here on the right-hand side, you see Pope Francis embracing Dominic Gondreau, who is a young boy from Providence, Rhode Island. This picture was from about 2013-14, I believe. Dominic, if I showed the other side of the picture, you'd see that Dominic has cerebral palsy. And here you see Francis embracing this vulnerable, beautiful person. Now, what this points to is the principle of human dignity, that each and every person, from Francis to Dominic to me and you, has inherent dignity. Each person is transcendently valuable, images God, and is loved by God, so that no one person is any more valuable than another. St. Thomas Aquinas talked about this in his Summa Theologia. He says, a person loved by God is more valuable than all of the galaxies. Take everything in the universe and put it together, and a single human being is more valuable than all of the galaxies. So we can't measure human value. And in this way, we're equal. And maybe it's the only way we're equal. Some are smarter than others, some are stronger, some are more virtuous, but no one is more valuable than anyone else. And this is a bedrock, foundational principle of Catholic ethics. It's an important principle. I think that the Catholic ethics needs to share more with the world. Each person is equal in dignity. This dignity can't be lost, nor can it be increased. So criminal activity, people who've done terrible things, they're no less dignified than you and I, Dominic and Pope Francis. The next concept is the virtue of charity. So charity is the virtue or good habit by which we love God and all who God loves. That means we love God and all of our neighbors, even our enemies, right? We find this in the scripture. We're called to love our enemies. We're also called to love creation. God loves God's creation, so too should we love God's creation. Now, a perennial question has been, why do we have to love the neighbor? Why are we called to love the neighbor? And the answer is simple. Well, it's not simple in this way. First of all, we can talk about an analogy that, again, Thomas Aquinas talks about. And he says, in order to love a friend, we've got to love all their friends. So think of a friend in your life. Think of one of their friends who isn't one of your friends. Maybe someone who you don't even care to spend much time with. Are you good to that person? Likely you are. Why are you good to that person? Because we know intuitively that to love a friend is to love all of her friends, even those we wouldn't choose as our own friends. We love the friends of our friends. Now here's the kicker. Who are God's friends? Well, unfortunately for us, everyone. God loves everyone. So the people who we would choose not to be friends with, the people who we hate, our enemies, God loves. And that the Christian task is to let God's loves become our loves, so that we conform our loves to God's loves and not make God conform God's loves to our loves. Wouldn't it be great if God loved everyone I love and hated everyone I hated? But that's just not what we're called to do. We're called to love everyone who God loves, and God loves everyone. And God has special love for certain people. And this is where the preferential option for the poor comes in. So the preferential option for the poor is this principle that says we're first and foremost called to promote the well-being of the most vulnerable members of our community. Who are they? They're the materially poor, the sick, the disabled, immigrants, undocumented people, racial and ethnic minorities, persons with substance use disorders. These are the people who are marginalized. These are the people who are often powerless. And that we should have a special love for these people, because as we read the gospel, we see God constantly opting for the good of the most vulnerable in our community. And we do this all the time in our own families, with our own friends. We opt for the well-being first and foremost of our young children, or of our disabled family members, or of our elderly family members, right? We make these choices already. And this is a bedrock Christian principle as well, that we should opt for the most vulnerable. Why? Because God has a special love for the poor. And so too should we who believe in this God. Remember, we're called to conform our loves to the loves of God, the love that God has for persons. And God exercises a preferential option for the poor, which is clear throughout the scriptures, especially seen in the Gospels. So part 2, Catholic end-of-life ethics. And you'll have to excuse me, I have some allergies, so I'll be drinking more water than normal tonight. So let's talk about temporal life. So life is a great good. The tradition has consistently affirmed the goodness of life, from the Gospels through the writings in the early church, through Aquinas, and up to the present age. Temporal life, life in time, is a great good. And we importantly have an obligation to preserve and sustain our lives and do nothing that intentionally shortens our life. Because life is a gift from God, life is intrinsically valuable, so we should never harm our lives intentionally or the lives of other innocent persons intentionally. Francisco de Vitoria, an important theologian in the beginning of medical ethics, he's writing right as new advances in medicine are happening in the 17th century. And he's being asked all of these different questions from the laity who are saying, what am I bound to do? I know I'm obligated to preserve my life, but what are the limits of that? Are there limits? And he says, yes, there are limits. He says, no one is held to use the foods that are the best or the most healthful. And here on the right, you see what looks to be a Thanksgiving dinner. We're all going to eat unhealthy foods in the next month or, next 6 weeks and, even further into Christmas and New Year's. We're not bound to always eat the most healthful foods. We're doing this to feast, to celebrate. But we're not bound to eat all of the most healthful foods so we live the absolute longest that we could possibly live. Nor, he writes, are we bound to use all of our inheritance, or by that he means money, to preserve our lives. One of the big reasons is that if we have families, our family members need that money to preserve their lives. So we should think about others as we use resources in the preservation and sustenance of our own lives. So the point here is this: the obligation to preserve life is limited, and that is from the very beginning of the end-of-life ethics tradition as we can see it begin to develop in the writings of Francisco de Vitoria. Juan Cardinal de Lugo, who's writing also in the 17th century, goes a little further. He develops this tradition a little bit more. De Lugo is asked a whole bunch of questions about amputation, and in this kind of wild case of a person who's being burned at the stake and is given a cup of water to quench his thirst. The question is that person obligated to use that cup to douse the flames so that he can live 2 or 3 minutes longer? So he's getting all of these questions, some of them crazy, other questions are not. The questions of just basic questions of amputation. Am I obligated to undergo an amputation? And as he begins to discern the correct moral solution to these cases, he says, we should begin to think about our use of medicine in terms of the benefits that it provides and the burdens that it imposes. So this benefit-burden dialectic, or benefit-burden proportioning, that he invites us to, that really influences deeply the tradition that is to follow. And the answer to the fire and the cup of water question is, no, you aren't obligated to use that cup of water to live only a couple of minutes longer, because the duration of that benefit is so short as to be futile or useless. And we have no obligation to use useless or nearly useless means. So here he's introducing the concepts of benefit and burden, and also the duration of the benefit. We'll see that later on in the talk. Reflect. Okay, here we are. Core concepts for Catholic end-of-life ethics. The first one here on the left is this concept of proportionate means. So if you go to a Catholic facility, the ethics committee is going to be looking at cases in light of these concepts, proportionate means and disproportionate means. And in fact, all Catholics are invited to analyze their end-of-life care in light of these concepts. So proportionate means exists when there's a medical treatment that's given to an individual patient that is both beneficial, it sustains or preserves the life of the patient, and can be realized without excessive burden on the patient and the family. So here, the benefit outweighs the burden. The benefit outweighs the burden. And if that is the case, the benefit outweighs the burden, the treatment is morally obligatory. Remember, we're obligated to preserve our lives. Our lives are of great value. Therefore, if the treatment has a reasonable hope of success and doesn't impose excessive burdens on us, we're obligated to use that treatment, because life is a great good and we must care for our lives. But not all treatments offer a reasonable hope of success. Some treatments are medically futile. They have a very small chance of meeting their intended outcome. So the treatment doesn't sustain our life or is unlikely to help us to keep living. And if that's the case, it's automatically disproportionate means. The burden of the treatment outweighs the benefit of the treatment. And in those cases, the treatment is considered morally optional. We don't have to use disproportionate treatments. We don't have to use treatments that are useless. Remember De Lugo. De Lugo said that already. And there's another situation that's a little bit more complex. There are many treatments today that have a reasonable hope of benefit for a patient. The treatment is probably beneficial, but modern medicine imposes many burdens on patients, some of them very excessive. So some cancer treatments give a patient a 33% chance or 25% chance of living 5 years. But there are massive burdens that treatment imposes in terms of pain, time in treatment, rehabilitation, monetary expense, lethargy, and the inability to worship God and be with others. So even a treatment that has a reasonable hope of benefit can be rendered disproportionate. That is to say, morally optional, because it imposes so many burdens on the patient. So here the burdens outweigh the benefits to the patient. And so we're not obligated to use that kind of a treatment, even a treatment that can keep us alive. And if you want to read more about this, see the ethical and religious directives for Catholic healthcare services that the U.S. Catholic bishops produce. And it's in its 6th edition. So you may be asking, who decides? Who decides where the benefits and burdens are? Who decides if a treatment is proportionate or disproportionate? Well, the patient decides if she can. She discerns the benefits and the burdens because she knows best what are benefits for her and what are burdens for her. So the patient decides. The church gives the patient a lot of autonomy to make decisions about her medical care. A proxy will decide if the patient cannot. If the patient lacks capacity or intellectual ability to understand treatment options, then a proxy or a surrogate makes that decision. And the proxy, and increasingly we see proxies making medical decisions because we can keep very, very sick people alive for a very long time. People who lack capacity, lack the ability to reason. And so increasingly we see proxies and surrogates making these kind of decisions. A proxy should consider the benefits and the burdens of the treatment, just like we suggested, and the best interest of the patient. What is in the overall best interest of the patient, given the benefits and the burdens that face that patient? The proxy should also consider a patient's previously stated wishes, maybe written down in an advance directive, a living will, that further serves to facilitate the discernment of the burdens and benefits. If a patient has said, I don't want certain treatments, well, that treatment is considered burdensome by that patient. Maybe, that will make a difference as we decide for a patient what ought to be done and what ought not to be done. So you may be asking, what are potential benefits and burdens? What do you mean by a benefit and what do you mean by a burden? Well, here we see that the tradition has codified what is typically considered a benefit. Benefits from a treatment include that a treatment sustains our life, it preserves our life, it causes us to keep living. That's clearly a benefit. But we also have to ask, how long is that benefit going to exist? How long will the treatment enable us to live? A treatment could restore our health, so that's clearly another benefit. Finally, a treatment could enable us to have our relationship with God and neighbor, to keep sustaining that relationship, to develop that relationship, to grow that relationship. At the end of life, a treatment may help us to live longer so that we can become in right relation to God and others. We may need to reconcile with God and others. And so a treatment that gives us a few extra months of life may be an enormous benefit for a person who needs to rectify his relationship with God and his family and his friends. Where are the burdens of a treatment? Well, the treatment would be considered burdensome if it requires heroic efforts. Imagine a person who's receiving dialysis, who lives 150 miles away from the dialysis center. They have to drive 3 days a week, 300 miles round trip to be dialyzed in order to sustain their life. That's heroic effort. We're not obligated to use that level of effort to keep ourselves alive. A treatment can be burdensome if it induces excessive pain. If it, we can manage a lot of pain in the United States today. But you've got to remember, this tradition is developed not just for people who live in the United States or in Western Europe, but rather for the whole globe. There are places in the world, unfortunately and terribly, that don't have access to things like morphine. In this country, we can control most pain, but not all pain. So pain we still have to consider to be a burden that a treatment can impose on a patient. A treatment can impose substantial financial expense on a patient. It can be incredibly expensive to use many of these treatments. We saw that earlier. We're not obligated to use all of our money or all of our family's money to keep ourselves alive. Treatments can induce reasonable fear. Maybe there's a spinal surgery that's been offered as a life-saving treatment for a cancer. Well, there's a chance that a person could end up a quadriplegic from that surgery. Some people say, I would rather live as I am right now, knowing that that cancer will kill me, as opposed to risk being in a situation that I don't want to be in, that I have a reasonable fear of ending up in. So fear should be considered. And then finally, as I said regarding the benefits, certain treatments can impede our relationship with God and others. So certain cancer treatments render patients lethargic, unable to eat, unable to move around, unable to see friends, unable to attend Mass and receive the sacraments in the way that they want to receive the sacraments. So some people, knowing that that would happen, that a cancer treatment would render them not able to do the things they want to do regarding their relationship with God and neighbor, will forego the treatment, even if it could be beneficial, because they want their last months to be spent with others and in worship of God in the way that they want to worship God. So here I offer the case of Mr. I, a case that I've encountered at Catholic Medical Center. Mr. I was a 59-year-old man with many comorbidities. He was DNI, DNR, so do not intubate, do not resuscitate. He called an ambulance because he was short of breath when he was at home. The EMTs found him unconscious and not breathing. He was intubated. He was put on a ventilator, which was against his wishes, right? He said, I'm DNI, do not intubate me. And that intubation actually caused an esophageal hematoma, swelling in the throat. His family came in and said he never wanted any of this. Remove that ventilator immediately and allow him to die. The physicians said, no, we've got to assess his brain capacity. He may still have brain waves. It's likely that he suffered some brain damage because he wasn't breathing for a while, but we don't know, and we'd like to figure out how much brain damage he's suffered, because he might not have suffered all that much. The family was adamant, so it went to an ethics consult where we were called in to assess the case. And when we looked at the case, we discerned that the treatment was disproportionate for Mr. I. All treatment, when we talk about proportionate and disproportionate means, we're always talking about an individual patient. It's not as if ventilators are disproportionate by their very nature. No, a ventilator can be proportionate for some, more beneficial than burdensome, or in the case of Mr. I, more burdensome than beneficial. He thought that this was a burden he did not want to undergo, and that any potential benefit was outweighed by the imposition of burden of the ventilator. And so we should normally follow the wishes of a patient in this situation, especially if they've made their wishes known. And so we discerned that the treatment was disproportionate, and the Catholic facility could rightly remove the ventilator and allow him to die of his underlying pathology. Which brings up a really important distinction, a distinction that doesn't always get articulated in the way that it should, or in the way that it is in the tradition. There is a very important distinction between killing a patient, that is doing an action that by its very intention ends the life of a patient, and allowing a patient to die of an underlying pathology. Here in the removal of the ventilator, we have allowed Mr. I to die. It is permissible to allow him to die if the treatment is burdensome, if it's disproportionate, life-sustaining treatment. Here, the physicians did not kill the patient. They simply stopped burdensome means, burdensome, disproportionate treatment. An incredibly important distinction that often gets muddled in conversations about these kind of things, especially around the removal of a ventilator. Ventilators are removed in Catholic hospitals every day. It's a fairly common practice and a morally permissible one. One of the things we see here in the tradition is that life is a great good, but it is not the greatest good. Life is not the greatest good. We don't live to live. We live to love. We live for the sake of our friendship with God and all of God's beloved. So the Catholic tradition is decidedly anti-vitalist. Vitalism is the notion that life is the greatest good and that we should do everything in our power to preserve and prolong our life. The Catholic tradition does not think life is the greatest good. The greatest good is loving God. Life is a great good, but it's not the greatest good. So we don't have to do everything in our power to keep ourselves alive. And this is kind of getting to the point, charity is the greatest good that I've referred to earlier, this love of God and neighbor. This is why we are here, to love. Part 3, the Ars Moriendi. And I'm looking at the time, and I'll have to speed this up. I may cut some slides here. So the now disgraced filmmaker Woody Allen captured the zeitgeist of the nation regarding death. Death is a taboo. We don't talk about it. We don't think about it. We don't talk about what a good death might look like. And he noted, I'm not afraid to die. I just don't want to be there when it happens. Here, the good death is the oblivious death. But there's another way. There's the Ars Moriendi, this art of dying well tradition that was developed in the 15th, 16th, 17th century. While death is not a good death is possible. A good death is possible when we allow ourselves to be cared for by God and others, when we open ourselves to the grace of God and the care and love of others. When we forgive others and we receive their forgiveness, right? We ask for their forgiveness. That our dying is really an opportunity to practice our faith, our hope, and our charity, our belief in God, our hope that God will save us, and our love of God and neighbor. This is a unique time. And we know this in our lives, that some of the most difficult moments of our lives are unique opportunities to be open to God's love, to receive God's love, and to love others and love God. This is just the way that it happens, that these difficult moments are often graced moments. It doesn't make them any easier or doesn't make them good, but they are often graced. And our dying can be graced and is not something we should be oblivious of, but something we should do with intentionality. How do we do that? It's going to be really hard to do that when we're dying. So life has to be a preparation for this. We need to prepare for this now, today, no matter how old or young we are. We need to practice what St. Benedict noted was the Momento Mori, the remembrance of death. So in the Rule of St. Benedict, he tells his monks, every single day, remind yourself that you are going to die. Sounds moribund. Sounds like something we don't want to do. We want to deny death. Death's a taboo. Don't remember death. Don't talk about death. Don't think about it. Benedict wants us to think about it. Why? Because this enables us to consider how we should live right now. It really throws into stark relief what our life is actually about. It's about loving God and loving others. It reminds us what is really important and that someday we will return to God. So let's start to prepare for that now. Let's start to prepare for that now. And this kind of reminds us as well that the best way to die is to live a good life. How do you die well? To live a good life right now. Those of us who open ourselves to God's grace and entrust ourselves to the care of others and love others. It will, when we come to our dying, it will not be easy, but it can be beautiful. It can be good. There can be a good death, but it's going to be really hard to do that at the end of life. We need to begin that process right now. And so the final part here, Catholic end-of-life ethics and COVID. So one of the shocking things during this whole pandemic is the impact of the virus on Black persons. So Black persons are 2.6 times more likely than white persons to contract COVID. They're 4.7 times more likely to be hospitalized than white persons are due to COVID. And they are 2 times more likely than white persons to die of COVID. Now, if we ever have questioned whether systemic and structural racism still exists in this country, it's clear it does. We've seen it on the streets of Minneapolis with the killing of George Floyd and throughout the country through the killings of so many others by law enforcement, and also through the unjust distribution of hospitalization and death due to COVID. Why is it that Black people are being hospitalized at such greater rates and dying at such greater rates? Well, the reason is clear. Our policies have set Black people up to be less healthy than white people. We build parks in white neighborhoods and not in Black neighborhoods. We care about air quality in white neighborhoods and not in Black neighborhoods. We give white people have much better access to healthy foods than Black people do for a variety of reasons. Economic reasons, reasons of economic justice, but also where supermarkets set up shop. So Black people end up with higher rates of obesity, diabetes, hypertension, asthma, all of which, these are the big risk factors for hospitalization and death due to COVID. And these are not accidents of history. These are caused by intentional decisions that have been made through the course of our history as a nation that have disadvantaged Black people relative to white people and have led to their deaths during this COVID crisis. So what should a Catholic response to systemic racism during COVID be? What does it look like? Well, we should be reminded that Pope Francis and the US Catholic bishops have argued that racism is a pro-life issue. If you are pro-life, you have to be anti-racist. You have to be against racism in all of its forms. Why? Because we as Catholics believe in the equal dignity of all persons. Black people and white people are equally valuable. They are transcendently valuable. Black people image God just as white people image God. The preferential option for the poor directs Catholic medical facilities, I argue, to really focus its outreach on Black communities first and foremost. If we're called to go out first to serve the most vulnerable in our community, then medical facilities should first and foremost outreach to these Black communities that have been so disproportionately affected by COVID. Second, I would say we should prioritize mask distribution, testing, and vaccine distribution for Black communities, because they are the ones who have borne the brunt of the crisis. Finally, I think we need to be more critical about how racism influences decision-making in medical institutions. That's a never-ending project, but I think we haven't done a good enough job of that. And that may play a role in some of the things that are happening now. And then kind of in general, I think the church has admitted, and I think it's absolutely right about this, the church needs a much stronger commitment to racial justice than it currently has. So I think it's turning more to the issue, but it's still insufficient, and we need more focus on this as a Christian community to address the structural factors that contribute to susceptibility to COVID. We need to change those factors. Okay, so further Catholic contributions, just in general, to medical ethics during the COVID-19 crisis. I think what Catholic ethics can contribute, first and foremost, is this notion of human dignity, that every man, woman, and child are equal in value, regardless of their disability, whether they have insurance, whether they're documented or undocumented immigrants, whether they're suffering from homelessness or suffering from a substance use disorder. All of us are equal in dignity. So no one should be at a disadvantage to receiving care. Some people have said, well, disabled people shouldn't receive ventilators if they become scarce. I fundamentally disagree with that based on the notion of human dignity. The disabled are equally as valuable and are equally as entitled to a ventilator as you, I, or anyone else. I think we should consider, Catholic ethics really asks us to consider the benefits and burdens of a treatment for gravely ill COVID patients. It helps us to discern treatments that must be provided, those that are certainly more beneficial than burdensome, from those that are optional, those that are more burdensome than beneficial. And the tradition reminds us that it is permissible to remove excessively burdensome treatment. Finally, the Ars Moriendi tradition, and I'll say more about this in the last slide, really invites us to attend to the spiritual and relational needs of the sick and dying, which I don't think we've done enough during this crisis, while also protecting the common good and public health. We have to remember that we're here to be in relationship with God and others, to love God and to love others, and that our spiritual and relational needs are just as important as our medical needs. So I think we need the tradition, the Catholic tradition, I think can share that with the community, the nation, and the world, in fact, during this difficult time. And we have an exemplar here of this. St. Camillus de Lelis, the founder of the Fathers of the Good Death. He started a religious order that was intended to help people to die a good death, to be accompanied, to be loved, to be cared for in their dying, not just treated medically, but treated as full persons, as in relationship to God and others. Okay, last slide. Is it possible to die a good death during COVID? Well, it's difficult, certainly. It certainly is. Here you see the picture on the right of the man who's presumably talking to his family members while the medical professional holds the iPad. While this in certain instances may be all we can do, do we need to do better? I think we do. I think we can and should do better than this. The Ars Moriendi tradition invites us to balance public health needs and the needs of persons dying with COVID. We have to be reminded that there are competing goods here, that the good of dying a good death, surrounded by loved ones and by priests and religious leaders and receiving the sacraments, is a genuine good. It's a very important good. Public health goods are certainly important as well, but we have to figure out a way to try to achieve both of these goods. And we have to live within the tension of trying to help people die a good death while also protecting the public. We don't want to do anything that exposes the public unnecessarily to this terrible disease. But at the same time, we need to be creative about helping the dying die good deaths, surrounded by their family and friends. Pope Francis has intimated the same point that I'm making. in his recent encyclical that was released this month, Fratelli Tutti, paragraph 19, he basically urges family members, don't abandon the dying during COVID. Don't abandon the dying during COVID, that they shouldn't just be treated by medical professionals, but that they should be cared for by family members and enabled to be loved and to give their love to family members and receive love back. That we need to be there for our dying members of our family in their last days. There's no easy solution here, but I think we need to live within this tension a little bit more. Thank you very much for listening, and I'll turn it back over to Megan.
Thank you so much, Dr. Daly. You gave us so much to think about in such an organized manner, so really appreciate your presentation. We have so many great questions. Some you've touched on as you made your way through the presentation, but I know that one of our attendees was asking if you could please speak a little bit about euthanasia.
So yeah, euthanasia, physician-assisted suicide, very controversial topics. Euthanasia is trying to give someone, the Greek root is to give someone a good death. This is not at all connected to the Ars Moriendi tradition. In fact, it's the exact opposite. Euthanasia is where a medical professional kills a patient out of a misplaced mercy, I would argue. Mercy is suffering with others to try to heal them of their suffering. Euthanasia annihilates the other. And it doesn't suffer with the other. It says that suffering's unbearable. I'm not, we're gonna take you out of that suffering. So certainly euthanasia has no place in the tradition that I've discussed. Our hearts break for people who request these kinds of things. But it typically, the studies show that typically people who request things like physician-assisted suicide or euthanasia, this is a cry to be loved and cared for. It is not that life is too painful often. It is a cry that life is meaningless, that they feel like they're a burden to others, that they've been abandoned by others. So our solution shouldn't be to kill them. Our solution should be to love them, to suffer with them. Suffering is a terrible, terrible thing, but there's nothing worse than suffering alone in many ways, right? And Catholics have always been called to suffer with the others, This is what the works of mercy are about. This is what Pope Francis has made the cornerstone of his papacy, is the virtue of mercy, that we should move toward the suffering. We are a suffering-averse society. We like comfort. Comfort is not an end in and of itself. There's nothing inherently wrong with comfort, but it should not be a goal of our life, given that we live in such a broken world where so many people suffer. If we live in a world in which so many suffer, and we aren't suffering to a certain degree, we have failed morally, terribly, I would say. So when people request things like euthanasia or physician-assisted suicide, those I think are cries for mercy more than anything. So the tradition that I've discussed categorically rejects both of them.
Thank you, Dr. Daly. In light of the end of your presentation, what suggestions do you have for dying a good death in these COVID times where it's so hard to be physically present with those that are suffering and sick?
Well, look, and like I said, Megan, this is a really, really tough, kind of the nuts and bolts of it. What do the practices look like? I suppose an iPad is better than nothing, but I think it's insufficient. I think we're so embodied, especially when we're suffering. We want to be in the presence of others. We want to be touched and held. We want to see the faces of others. They want to see us. They want to be in our presence. I don't know, I'm not an epidemiologist and I'm not a medical professional. So this goes beyond the scope of my competence to propose concrete solutions here. My point is this, is that those of us who do know this material, epidemiologists, people who know infectious disease, medical professionals, I think we need to do more work in that area. So as an ethicist, I'm saying, I think this is what we ought to do. Now let's get together and figure out what that looks like. Do we need special units that people can go into that are off the hospital grounds where dying patients can spend their last days, where the threat of spreading the disease within the larger hospital is lessened? Maybe. Do we need to be able to send certain patients home somehow? Difficult work. Maybe it's not possible for many patients. Again, this goes beyond the scope of my competence. But I think we need to think more about how to do this, that we need to do this more for patients. This is where we need a conversation among epidemiologists, physicians, nurses, social workers in the hospital setting.
Right, and just an extension of the question, we have a couple questions about, priests going to hospitals to offer the sacraments before patients pass, or Eucharistic ministers going, the risk that they take on.
And the Archdiocese has done amazing work. At the very beginning, Cardinal Sean set up a program so that priests could be trained to provide the Eucharist and last rites to patients. This, I think, was brilliant and important. I think it has helped people to die those kind of good deaths or better deaths than they otherwise would have died. And it's certainly a program that needs to continue. But as a point of fact, nearly every patient wants to be surrounded, if she's Catholic, by a priest, but also by family and friends. So a priest, I think, is necessary, but not sufficient. And so that's kind of my take on that. For most of us, we want everyone who we love and who we need at this time to be present for us. Right.
And it's tricky to think of the flip side, where are we ethically bound to keep safe the people that are coming in, to visit those, how do we keep those persons in mind as well?
Absolutely. Yeah. And we have to do that. I think that's a requirement. I just think we need to, we can find solutions to these problems, I believe. And experts, I think, can help us to do that.
Thank you. I'm going to just give a general announcement to everyone. We've got a couple questions about, will this be available afterwards? So we are recording it. They love you, Dr. Daly, and they want to see afterwards as well. So we are recording it, and we will have a transcript created as well. And so it just takes a little bit of time. And so it takes about 3 to 4 weeks for everything to be ready. And then we'll email it to everyone that has registered. And so you will be able to watch this again. So thank you for asking. We had a couple questions about that. Okay, more questions for you. We had one of our attendees ask about the financial aspect of all of this. How does that play a role when you're looking at treatment, especially in the US, where our health care coverage might not cover the things that we need?
So the tradition, as I noted, has always said that we need to attend to the financial cost of life-sustaining treatment. That matters. In a wealthy society like ours, we can distribute that cost among all of us. So we can socialize these burdens. They don't need to be individualized, that each individual family or individual has to bear the full cost of a treatment. The sad fact is that medical bills are the #1 cause of bankruptcy in the nation. So many patients go bankrupt by trying to sustain their lives, or go bankrupt and then die, and leaving their family bankrupt, holding the bill, so to speak. My argument is that we need to socialize these costs. We need to share this burden throughout the whole society. That's the essence of mercy. Now, there are going to have to be limits. Human medical need is some theologians have said, is a bottomless pit. There's no, we can always try something else. We can always do something that's experimental, at great cost and probably marginal benefit. And I'm not saying that we're obligated to do everything. In fact, I don't think we are at all. I think that's a wrongful take on this, for a variety of reasons. But one of them is the cost of it. We could end up spending our whole GDP on medicine, but we wouldn't then be supporting education and the arts and you name anything that's important to you. The environment. So we can't do that. We do need to have limits. But I think that what we should have is a system that enables everyone to access a decent level of care. And we're not there yet. We're certainly not there regarding the whole life continuum of care from birth to death. And so my point is, yes, we do need to consider the finances, but we need to spread those burdens out among the whole community.
Thank you. I'm going to combine two questions into one, where you spoke specifically about race and the COVID crisis. Our attendees would love to hear more about your thoughts about how class impacts healthcare ethics, and then as well as, LGBTQ communities.
Certainly, yeah. I mean, so the first one, class, and I was getting at that, I think, in just the last, economic class. Certainly, huge disparities in how the wealthy and the poor die. So we've done a terrible job as a nation of providing equitable care, of giving everyone access to care. And the U.S. Catholic bishops are clear about this, that medical treatment should be given out first and foremost based on need and not on the ability to pay. So class should never become a barrier to, to the foundational kind of level of care that we owe everyone. LGBTQ people and issues facing them, certainly they have been ignored in the hospital by and large in this country. And we're just finally starting to recognize them and the issues that they have that might be unique to their populations. So certainly we need to do much more work on these issues. There's so much to be done on, LGBTQ rights and people in terms of how they're cared for in Catholic hospitals. We're just now coming up with what's the language that we use when a transgender person comes in to a Catholic hospital? Do we use the pronouns that they use, or do we use their, quote unquote birth pronouns? I think the best answers are we use the pronouns they use. We treat them as full persons. This is clear, I think, in the tradition. There are some in some Catholic ethicists have argued against that. I think they're wrong. We need to do certainly more work with these kind of patients to respect who they are, that they are God-loved just as much as cisgender people or straight people.
Thank you. One of our attendees has posed more of an example of a person that perhaps is in a situation where they're unresponsive. It's really unable to learn from the patient themselves what they would consider benefits and burdens, and how do we make the decision of, how are they able to love God and love others, where those decisions fall.
Yeah, so those are some of the hardest cases where patients haven't expressed any, prior wishes in terms of their end-of-life care. The hardest cases that we've actually all too tragically see on a regular basis are the cases in which a person has not stated any wishes and they have no family and friends. I mean, these are the heartbreaking cases. So there's no one who knows their values. There's no one who knows their story who could say, I think for him, his time is concluded, or not. I think he still has more living to do. So let's do everything we can do to keep him going. We really lean heavily in end-of-life ethics on those kind of insights, whether they're from the patient herself or from the patient's family. The hardest cases are the ones you're talking about, and that's where we make decisions based solely on the best interest of the patient. So you do consider things like the age of the patient. You're going to do more for a patient who's a little younger, likely, than a patient who's a lot older. The condition, the burdens that the treatment is imposing, the possibility that the patient will survive the treatment or will regain capacity. The analysis is not mathematical. So this is where it's a big dialogue in an ethics committee. So it's anywhere between 11 and 15 people on a committee debating this from different perspectives. So there are ethicists, there are physicians, there are nurses, social workers, priests, you name it, CEO of the hospital. So that's kind of where those cases go. And typically what you want to come to is an understanding of, for this patient, what is in her best interest.
Thank you. And I think this will be our final question. What could be our biggest takeaway? All that you presented on COVID, on race, about being pro-life and loving God and loving others. What do you think we should walk away from your presentation?
Well, I think the Catholic end-of-life ethics tradition has so much to offer us. In fact, it's had an enormous impact on secular end-of-life ethics. So much so that secular end-of-life ethics, with the exception of some of the issues such as euthanasia and physician-assisted suicide, which have gone in a different direction than the Catholic teaching. But secular end-of-life ethics has been enormously influenced by Catholic end-of-life ethics. And in this moment in which we're facing this pandemic, I think we need to turn again, not only as Catholics, but as a nation, to the insight, to the wisdom, the collected moral knowledge of the Catholic tradition. I think it has so much to offer us regarding how we should treat the disabled, racial and ethnic minorities, people at the end of life, how we should care for them, allow them to be cared for by others. I really think that is, there's a treasure here that ought to be shared with more broadly, because we lack these kind of values. We lack, there's a kind of interminable debates going on. We need to have some values. And I think we need to put Catholic end-of-life ethics out into the public space, into the marketplace of ideas, to share with all Americans, and in fact, everyone in the world, about the insights here that have been drawn upon for, centuries by the secular world. And I think, again, as a nation, we need to turn back to the insights of this really rich tradition to see what it means to care for patients, to what must be done and what is morally optional at the end of life, and then what it means to die a good death. That I do not think is a conversation that's happening adequately in this country at this time. And I think absolutely needs to. People are dying deaths they never wanted to die. And this should matter to us. We've got to get over the taboo of death and recognize that we can die well. And we need our structures, our institutions, our hospitals to recognize that in addition.
Thank you so much, Dr. Daly. I know I can summarize from some of the posts people have made. They're very appreciative of your talk. They could have listened for much longer, but we're hitting our 7 o'clock deadline. So many thanks to you, and many thanks to all of our attendees for joining us today. Thank you for spending your evening with us. Just a quick reminder, we have 3 additional opportunities, 2 in English, 1 in Spanish, to participate in our webinars. Check out the link in the chat for registration links. The next one is on Thursday, November 5th at the same time for our annual Pine Lecture on Ministry with Persons with Disabilities, featuring Boston College professor Dr. Jessica Black, who will offer a presentation on spiritual and religious development in neurodivergent children and adolescents. You'll receive a follow-up email tomorrow, which will include a link to register as well. Thank you so much, Dr. Daly. Thank you so much to all of our attendees. Have a great evening.
Thank you.